session.
Thanks very much, Sophie. And before we start, I mean, big applause to Sophie for organizing all of this. I don't know how you managed to do it, sort of having to run all of the allergy services in adult medicine. It's extraordinary achievement. And I think the fact that it sold out within 5 weeks, and you look around this room, how many people there are, as Sharon Hall just said, it really is a marker of the fact how uncomfortable we all feel in this particular area and how much education we need. So the first session is going to be about epidemiology of fatal anaphylaxis, personal views, and a little bit of TED Talk on social media. So it's kind of really nice and varied. So rather than stealing the time from our speakers, I'll start by introducing Paul Turner. Obviously, I've been working very close with Paul over the last 3 to 4 years. He is absolutely spectacular in future of allergy, certainly food allergy in this trust country and I think globally, and has done fantastic work about epidemiology of fatal anaphylaxis. So Paul, over to you. I'm really looking forward to what you have to say.
Thanks, Adnan. Good morning, everyone. Sophie and organisers, thank you so much for having me. I do feel a bit of a fraud here because I really struggle with drug allergy, as I think do most paediatric allergists, and in particular, perioperative anaphylaxis is always incredibly challenging, and we are very fortunate to have a lot of expertise over with our adult colleagues at the moment. I hope it stays that way. So, fatal anaphylaxis. This is some work that I started doing as part of my MRC grant to begin to understand risk factors for very severe and fatal outcomes in anaphylaxis in the UK. Just to sort of ease us in, because I know it's only just gone 9:30 and I'm still waking up. So anaphylaxis itself has a interesting backdrop, but I think it's important at the start to try and get the framing right for anaphylaxis. It's the opposite of prophylaxis, what we do for vaccination. The concept is there's a lack of protection resulting in anaphylaxis, resulting in an uncontrolled immune response to a trigger that we probably shouldn't be responding to. And there are lots of hypotheses as to why we have pathways that can cause fatal anaphylaxis. There are lots of definitions out there. My favourite one is the one from the Australian Allergy Association, ASCIA, a rapidly evolving multi-system reaction characterized by one or more symptoms or signs of respiratory, cardiovascular, and or other systems such as skin or gut involvement. And I think it's important to get that up front because even in the NAP6 report, there's a discussion as to the controversy on exactly how we define anaphylaxis. And I want to touch on that in a few slides' time. Anaphylaxis was observed, I would say, rather than discovered by Charles Richet, who ended up winning a Nobel Prize in 1913, and Paul Portier. And this is in the good old days where we weren't in decrepit buildings belonging to UK universities, but we would do research on board the Princess Alice II yacht in the Mediterranean, with Prince Albert I on board as well. And their work was basically in a time of when smallpox vaccination was beginning to emerge as a route to protection from disease. They wanted to see if they could protect a dog from a jellyfish sting by the Portuguese man-of-war jellyfish, that's why they were in the Mediterranean, by stinging the dog, and then try stinging again. And maybe very small stings will gradually build up protection, like it seemed to be the case for smallpox vaccination. And so poor Neptune, the dog, didn't actually do very well, and basically sort of collapsed in a heap, had bloody diarrhea, and died of anaphylactic shock. And one comment Charles Richet made later on when he was awarded the prize, it wasn't just for anaphylaxis, because there were other people involved, of course, Paul Portier too. He was actually quite a prominent researcher, medical researcher in other areas as well. But he says this thing, which really, I think, rings home to me and some of the work that I'll talk about in the next 10, 15 minutes. It wasn't due to deep thinking, but actually just observation of medical researchers and indeed medical practitioners are losing. Everything is like textbook and regimented now. And I think there's a lot in there, particularly if someone's having, I'm not an anaesthetist. I wish I was sometimes when I give people food-induced anaphylaxis. And I think in terms of the observation, I think there's a lot we can still learn from that to try and understand how things are happening, be on the ball, and actually respond accordingly. The most commonly used definition for anaphylaxis is the NIH NIAID definition, which was then adopted by the World Allergy Organization in 2011. And there are various issues with it, which I won't bore you too much about. They're more of an issue in terms of food-induced anaphylaxis and perioperative anaphylaxis. But essentially, we're talking about an acute onset of illness, and again, respiratory or cardiovascular presentation. Sometimes, and this is one of the points of contention, you can just have skin and gut, and we argue about whether skin and gut alone constitutes anaphylaxis or not. And quite clearly in NAPSIC, that was excluded from being termed anaphylaxis. In the UK and Australia, we likewise include food-induced reactions, typically as not being anaphylaxis if it's just skin and gut. Increasingly, sometimes we see just respiratory presentations without cardiovascular presentations to an allergen. And so again, this probably needs a little bit of work done now. And there are updates that are planned over the next couple of years on these definitions by WA and the American colleges and possibly IACI. Now, just a quick note on nomenclature. So these are different definitions that various expert organizations around the world have come up with. And you'll see that both IACI, it's serious allergic reaction, but it's on a spectrum. And there's mild to moderate anaphylaxis, if that makes sense, through a spectrum to life-threatening anaphylaxis, through to anaphylactic shock. And that's something that's quite important, particularly for patients, because most patients who've experienced anaphylaxis, or in my particular setting, most parents whose children have experienced anaphylaxis, and I'm one of them, my kid has had anaphylaxis to a drug, we will think that, oh my God, my kid's going to die next time they get exposed to X. Often that's a food in the case of pediatrics. And I think it's really important that in terms of management of the patients who have had allergic reactions, and particularly anaphylaxis of whatever cause, we don't lose a message it can be life-threatening, but likewise, we need to try and tackle the perception that it's a one-way street to death, because anaphylaxis generally is not, although the stakes are a little bit higher in terms of the perioperative setting. In NAP6, the definition they used was the IACI definition, this one here, severe life-threatening generalized or systemic hypersensitivity reaction. That was interpreted as, well, if it's not life-threatening, it's not anaphylaxis. And we'll talk about that in a second. I checked my facts. I spent a lot of time rereading the NAP6 report last night. And importantly, in the original article by Johansson and colleagues, it quite clearly says hypertension, severe bronchospasm do not have to be present for a reaction to be classified as anaphylaxis. In terms of what happened in NAP6, they used a Scandinavian classification that was derived from Ring and Mesmer. Ring and Mesmer sort of went up to that part. Scandinavians added fatality in. And 3, 4, and 5, grade 3, 4, and 5, were included as anaphylaxis in NAP6. One, I would argue, is not anaphylaxis, and NAP6 report likewise said so. Group 2 is the interesting one, because here we're talking about unexpected hypertension and or bronchospasm, but not severe stroke life-threatening. And many allergists would argue that that is still anaphylaxis, although in a NAP6 report, it sort of argues it wasn't anaphylaxis and therefore wasn't included. I think it is very appropriate not to include those reactions because we really have much more to learn from the more severe reactions, and we don't want to dilute any potential signals of risk factors that might exist. But on the other hand, I'll come back to this. I think it's important not to turn around and say that's not anaphylaxis. The NAP6 report does make reference to the new criteria being suggested by Rose and colleagues a couple of years ago in an editorial in BJA, where they do indeed talk about 3 grades and moderate perioperative anaphylaxis, which may often need treatment. It's not just anaphylaxis that doesn't need treatment. And I think the reason that matters is because A, we can't predict severity of reaction when people are exposed to an allergic trigger, a known allergen. We don't know the relationship between the dose of exposure and the severity of the reaction. And so a lot of people who don't have severe life-threatening anaphylaxis, that might not be because they've only been exposed to a small dose. And again, one of the things that I'm sure we'll hear during the day is how the use of test doses, particularly for antibiotic treatment, isn't particularly helpful and is potentially quite dangerous. This concept that somehow a low dose is safe, we're not going to end up with a severe outcome due to that. And thirdly, this is the group that actually we need to make sure we're getting it right in terms of documentation and communication that they are at risk of future reactions. And in the UK fatality data set, and that's been reproduced across the world, we'll see how these less significant anaphylaxis reactions, or even non-anaphylactic reactions, are often the precursors to a severe fatal event. And most people who die of anaphylaxis have not had a previous severe reaction. So somehow we need to capture these people, and we've just got to be quite careful that we don't get a message out there that somehow these non-life-threatening anaphylaxis reactions aren't anaphylaxis. I would argue that they still are. But in terms of the NAP6 methodology, I think it's completely appropriate to focus on these ones here, because that's where I think there's a lot more learning to be done, and it's the most excellent report in my opinion. So anaphylaxis all-cause is actually pretty uncommon, and there's some data up there. This is particularly interesting. Lifetime prevalence in the UK population, it is a little bit old, back in 96 now, so 26 years old, but 20-odd years old. Probably hasn't changed so much. Just over 1 in 1,000 for the UK population lifetime risk, which actually is surprisingly high, I think. Lots of causes, as you can see. We're going to drill on medication, iatrogenic causes today. Looking at the UK data set, we need to try and get trends, and this is something that's quite popular at the moment. I've been contacted in the last month or so due to some of the headlines about, is it true we've had 8,000 deaths due to allergy in the UK in the last year? And it's like, we've had 8,000 deaths where on the death certificate there's a diagnosis such as allergic rhinitis or something like that, but not due to a fatal allergic event. And this just highlights the issues that we have trying to get good epidemiological data for anaphylaxis in the UK. There's a lot of misunderstanding, and this includes by government agencies as well, in terms of understanding how NHS coding works. Quite clearly, there's been an increase in hospitalizations due to all-cause anaphylaxis over the last 20 years, as shown in this slide. But there are lots of limitations in how this data gets formed, created, and then how we might use it, due to underreporting. And having spent quite a lot of time working with Richard Pumphrey, who really was instrumental in setting up the UK Fatal Anaphylaxis Registry, which is now being taken over by Richard's colleagues in Manchester. And we've got Thomas and Nigel here today. I'm not sure if Viva's come down as well or not, or she's also got clinical commitments. But really, there is a huge, huge source of data that really is trumping any other country in the world at the moment in terms of what we might be able to learn from severe and fatal anaphylaxis. There is significant underreporting, particularly an issue for drug-induced anaphylaxis. If someone dies of food or a bee sting, well, that's not sort of really anyone's fault usually. It happens as a community event. But most drug-induced anaphylaxis happens as a result of prescription and often happens in hospital. And unfortunately, there is still a culture of trying to, well, it wasn't my fault when things happen and things go wrong. And from the work that Richard's done at the coronial level over the last 20, 30 years and really trying to understand causes of anaphylaxis, it's very tricky when it comes to anaphylaxis events due to a trigger initiated by a healthcare practitioner. And there is significant underreporting there. Again, something that's touched on in terms of the NAP6 report. There's also significant miscoding. Often we don't do the coding. The coding is done by junior personnel. The handwriting is illegible, although as we slowly are dragged into the 21st century, that's now happening on computer. But actually, it's an admin person who somehow has to pull out the relevant coding words for hospitalizations, and so that it can be appropriated accordingly to anaphylaxis, allergic reaction, or something like that. And actually, admin people aren't clinicians, and often there's significant miscoding. We know that from work Public Health England has done. Again, something highlighted by Richard Pumphrey, when you take cases of potential perioperative anaphylaxis and they actually go to the coroner and an appropriate investigation is done, there's often significant discrepancy between what the coroner ends up saying and what the investigation shows up. And again, that's partly because of the limited resources and the decline in the coronial service that we're having in the UK at the moment. And finally, a significant proportion of fatal anaphylaxis cases throughout the world are simply classified as unspecified cause. And often that's due to laziness. Sometimes there's an obvious cause, but the coroner doesn't want to know about it. I'm aware of a few cases of where there's a quite clear trigger and all the medical experts said this is the trigger and the coroner just said it's asthma and left it at that. So we've got to be careful how we interpret these data. And again, the NAPSIS methodology of getting the data from the source, as in the anaesthetists from local hospitals, really was, I think it's crucial. And if we can somehow build on that to build the anaphylaxis registry in the UK in the future, that would be great. Fatal anaphylaxis cases, what have we had? So just under 400 confirmed cases, and you can see the distribution by cause over the last sort of 20 or so years. Unfortunately, we're now about 5 or 6 years out of date. And drug argogenic causes makes up a significant portion, about 50%. We're not quite sure how much of this unconfirmed anaphylaxis is drug-induced, because again, there's a real slowdown and lack of provision and communication of the information that we need to come to that conclusion. There's a general trend for increasing hospitalizations, but actually the fatality rate has remained relatively stable over the last 20 years, which actually is quite reassuring. Dividing by food, drug, and insect, one can see, certainly for food-induced anaphylaxis, an increase in the young anaphylaxis in the younger people, possibly in the middle age, relatively stable in older ages, but stable fatality rate. Likewise for drug, although there is an increase certainly in the older age groups in terms of hospitalizations where anaphylaxis is coded for. Insect venom stings a bit hazy, a bit mixed, partly because of the decline in the bee population in the UK. We're not quite sure what the pattern is there. There's a clear age distribution with food-induced anaphylaxis causing fatalities, much more prominent in young people, and really drug-induced fatalities increasing in the older ages, particularly, but not just due to polypharmacy. Is this also due to comorbidities such as cardiovascular disease? In terms of the causes that we have in the UK, leading causes are antibiotics, and you can see sort of a bit of a split, equal penicillins and cephalosporins, but a significant proportion due to anaesthetic agents. And half of all cases where Richard and team were not able to work out what the actual trigger had been to a degree of certainty. What's concerning, I guess, for me, is that food-induced anaphylaxis, proper anaphylaxis, has a case fatality rate of about 1%. But in older age groups, we're approaching for drug-induced anaphylaxis 2 to 3%. And so actually, severe outcomes are more common with drug-induced anaphylaxis than they are with food and venom-induced anaphylaxis. And that's a pattern similarly that we're seeing across the world. So there's similar data that exists, although not in the form of a fatality registry, in the United States, in France, Canada, and Australia. And the rate of fatal drug-induced anaphylaxis is roughly around 0.2 to 0.5 per million people per year. And that might be increasing in Australia and the USA. In the UK, we haven't seen an increase in fatal anaphylaxis due to argogenic causes as yet. And we've got, again, some places report an age predominant, a gender predominance. Certainly everyone agrees it's something that we see in the sort of 6th to 7th decade of life and then increasing thereafter. And cardiovascular disease is often flagged up as a significant risk factor, although people will argue that's also confounded by the age effect. In Australia, actually a significant major cause, again, something that's flagged up in NAP6, is the history of prior allergic reaction, not as severe as causing a fatal event, and then that not being communicated or acted upon when people then get exposed to that medication again in hospital. And again, that's a real learning point, something that will come up later on in the day. But it remains rare. In the UK and in France and Australia and in Canada, you are still as likely to die due to lightning as you are due to perioperative anaphylaxis, fortunately. And I think that's in part because of the skill of anaesthetists in actually managing these severe reactions when they do occasionally occur. Drug-induced anaphylaxis, non-fatal, probably lies around here, about 50 to 100 times more common. There's not great data for that, and this is the UK estimates. But you can see that, again, interestingly, the rate of fatal venom, drug, or food anaphylaxis, they all overlap in this sort of area in an unselected population, which is often what we're dealing with in terms of perioperative anaphylaxis. Not all anaphylaxis is the same, and this is some really interesting work that Simon Brown and colleagues in Australia have led on in terms of looking at acute reactions presenting to emergency departments. And of 350 episodes in this prospective study that they did and published in 2013, Just under 100 were severe reactions. Now, I know probably most of you are thinking that's not particularly bad. But for an emergency context of anaphylaxis, I don't know, about 40, 50, 60 millimeters mercury in and that's it. This would constitute severe. If it's just an allergist without an anesthetic background, I'm going, okay, that's good going anaphylaxis there. And quite interestingly, looking at the likelihood of having hypotensive symptoms or hypoxic symptoms compared to food as a trigger, medication much more likely to have hypertensive reactions and hypoxemic reactions than food. And for allergists, we tend to know more about food, particularly if we're pediatric allergists, than the medication-induced. What's interesting to me is that we often think, well, actually, if you're injected with an agent, a parenteral agent, it gets very quickly into the systemic circulation. You're more likely to have cardiovascular symptoms with more rapid onset. Whereas food, you eat it, it's got to be digested, it's got to be absorbed, so slower onset. And therefore, drugs cause cardiovascular issues quicker than food simply because of the route of exposure. But their data, interestingly, showed that even oral medications were still far more associated with hypertensive reactions compared to food. So it's not just the route of exposure, it also depends on the allergen as well. And most of these medications, but not all, were non-steroidals. And we know non-steroidals often cause a different pattern of anaphylactic reactions compared to, for instance, beta-lactam antibiotics. And so there are differences that we see in terms of age distribution, in terms of the symptoms that people experience, in terms of looking for mast cell tryptase increases and potentially other biomarkers, depending on the trigger. Finally, coming back to my quote at the start from Charles Richet, many of you will, I'm sure, will be familiar with Malcolm Fisher's work. Malcolm is an amazing anaesthetist who was based at North Shore Hospital in Sydney. And basically, in the 70s and 80s, by just pretty much observation, collected a huge wealth of data relating to perioperative anaphylaxis. And he studied in quite a lot of detail 204 patients who had perioperative anaphylaxis. I hope that blood pressure is a bit more acceptable to the anaesthetist in terms of definition. Good, okay. And by using serial hemoglobin measurements, which were quite comprehensive in 22 patients and less comprehensive in more, he observed a change in hemoglobin consistent with a loss in circulating volume of about a third, occurring within 5 to 10 minutes of exposure to the trigger. And that's fast for people who haven't seen perioperative anaphylaxis. And even for me, looking through anesthetic charts, it still seems to be, if you look through and think, well, that was given then, sometimes you can still see significant delays, minutes we're talking about, in terms of symptoms. So to see 10% within 10 minutes, that degree of hypovolemia is quite impressive for me. Using CVP measurements and also pulmonary wedge measurements, putting the data together, an early loss in venous tone as well. So it's not just maldistribution, and it's not just hypovolemia, it's also maldistribution due to peripheral vasodilatation. And often there's evidence of myocardial dysfunction as well. He also observed nothing new under the sun. IV adrenaline with 5 to 6 litres of rapid fluid therapy seems to work, but that's still a message that we struggle to get out there. And even for allergists, we struggle to get people to use adrenaline in the community or the emergency setting, despite everyone agreeing it's a first-line drug of treatment. And again, nothing new under the sun, delayed adrenaline was common in fatal cases. Again, adrenaline needs to be used early, something that also has come through the NAP6 data. Finally, just to build the picture a little bit more, I came across this report a couple of years ago, and it's a prisoner who had taken an ACE inhibitor in the context of ibuprofen as well, who then became unwell in prison, transferred over to hospital, where about an hour after taking the lisinopril, came out in urticaria, and then someone thought, this is anaphylaxis, and then gave him IV adrenaline, fluid resuscitation, and so on. But due to ongoing significant gut symptoms, he ended up having a CT scan during his anaphylactic episode. It's the only case I'm aware of at all. And the CT scan, this isn't his, but this is very similar to the findings that were reported of what's colloquially called shock bowel. So, diffuse bowel edema, as you can see with the red arrows, which haven't come up very well, fluid in the lumen, significant fluid in the lumen, and a reduced caliber for the ascending aorta, diminished venous return. Where's all this fluid going? When people have anaphylaxis, they don't often puff up like massive balloons because they've lost a third of their circulating volume. It's probably all going to the gut. That's the mechanism that's happening here. So, in conclusion, what can we learn? So drug-induced anaphylaxis is the most common cause of fatal anaphylaxis in the UK and in most countries, but it's still relatively rare as a cause of death of any cause. And I think that's important for patients to know. Incidence of fatal drug anaphylaxis may be increasing, and we need to have systems in place and support those systems so we can actually monitor if this is the case or not. And the risk factors seem to be people over 50 years of age, often with pre-existing cardiovascular morbidity, and drug administration errors. And again, I think this is going to be an ongoing theme over the rest of the day. The most common drugs in the UK appear to be beta-lactam antibiotics, muscle relaxants being used as general anaesthetic, and radiocontrast agents. And I'm going to stop there. Thank you very much.
Thanks very much, Paul, for fantastic talk. I know that